Hello, everyone. Welcome to today's webinar. We'll be starting shortly, giving folks a couple of seconds to hop on the webinar. Thank you. Hello again. Good afternoon, everyone. Welcome to today's webinar. My name is Chinedu Okeke. I am from the Office of Infectious Disease and HIV/AIDS Policy. Next slide. So our webinar objective today is to provide an overview of the Viral Hepatitis Federal Implementation Plan. We will also try to define and provide any clarification and set expectations for the federal implementation plan. Finally, we will use this webinar platform to allow our stakeholders and the public to provide public comments. Next slide. So as you can see, we have a packed agenda today. Shortly, I will be introducing our HHS and federal partners who have graciously joined us in today's webinar. We will provide an overview of the Viral Hepatitis Federal Implementation Plan and the implementation plan components. Some of our federal partners that have joined us today will take turns to briefly highlight and provide a snapshot of some of their activities in the plan, including those activities that focuses on syndemic approach. We will also talk about the next steps for the plan and then follow up by the public comments. Next slide, please. So for a quick introduction of our HHS and federal partners, again, my name is Chinedu Okeke. I am the Acting Chief Medical Officer at the Office of Infectious Disease and HIV/AIDS Policy, and also the Viral Hepatitis Division Lead for the office. Joining me today from the same office is my colleague, Dr. Jessica Darin, who is a Viral Hepatitis Policy Advisor. Joining us from CDC is Dr. Carolyn Wester, who is the Director for the Division of Viral Hepatitis. Also from NIH is Dr. Jay Hufnagel, the Director of Liver Disease Research Branch, NIDDK. From the Substance Abuse and Mental Health Services Administration, SAMHSA, is Kristen Roja, who is a Public Health Advisor. From HRSA is Dr. Ronald Wilcox, who is a physician at HIV/AIDS Bureau. Finally, from the Indian Health Services is Rick Havocate, who is a National HIV/HCV consultant. Next slide, please. So before we delve into the Viral Hepatitis Federal Implementation Plan, I wanted to provide some background and context that led to the development of the Federal Implementation Plan. Some of you already know that the National Strategic Plan released in January of this year was developed by subject matter experts in 20 federal government agencies with inputs from a variety of stakeholders under the direction and coordination of the Office of the Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary for Health. It is, in fact, the first viral hepatitis national strategic plan with a roadmap to elimination. We all understand that its success depends on the active participation of the national, state, local, and tribal health departments and organizations. Also, corporations of the health plans, healthcare providers, community health, faith-based organizations, scientists, and the public. So to be clear, it is a whole of society approach. although we know that implementing this national strategic plan is not solely on the federal activity, but we are trying at least, and we wanted to, set an example and lead the way by being transparent, holding ourselves accountable, in addition to identifying areas of collaboration. Now, before I hand over to my colleague, Dr. Darin, I wanted to provide a quick definition for this federal implementation plan. So this is a viral hepatitis federal implementation plan sets forth the federal partners' commitment to policies, research, and activities during the fiscal year 2021 to 2025 to meet national strategic plan goals pursuant to their respective missions, funding, and resources. Next slide. Now, my colleague Jessica would take over to provide more details about the federal implementation plan. Jessica, take it over.
Thanks, Dr. OKK, and welcome everybody. So the Viral Hepatitis Federal Implementation Plan was developed in coordination with federal partners. And the goal for the implementation plan is to provide transparency in the actions and funding federal agencies are taking and working towards the goals of the National Strategic Plan with the ultimate goal of viral hepatitis elimination. Public comment was requested at 2 time points during development of the National Strategic Plan, at beginning stages and on the draft strategic plan. These comments were shared with federal partners to inform their implementation activities earlier this year, followed by data collection on the implementation plan this summer. I want to reiterate that this implementation plan is a federal implementation plan, while the National Strategic Plan is a plan for all stakeholders, not only federal partners. The implementation plan only includes activities that the federal government is able to do and fund with the resources available. But we hope the federal implementation plan will be a useful guide for all stakeholders' work in viral hepatitis and can be used to identify areas within the National Strategic Plan that partners can support and help fill gaps, because we know that there is more that can be done outside of what the federal government can support. Here we list all of the federal departments and HHS agencies or offices that were involved in developing the draft implementation plan. And thank you to all of our partners for contributing to this plan and making the federal government's work in viral hepatitis as transparent as possible. Next slide. The draft implementation plan is organized by goal, objective, and strategy. Federal partners provided the action steps that fall under each strategy. The columns include the action step, timeframe, lead and partner agencies, indicators that the action step is aligned with, and the funding mechanism. The time frame for each action step only includes fiscal years from the National Strategic Plan, that is 2021 to 2025. So if an activity occurred before fiscal year 2021, it will still only list 2021 as the earliest year. And any activities that may go beyond fiscal year 2025 will only be listed as 2025 in the implementation plan. Not all action steps are aligned with indicators or funding streams, but we have included the indicators that federal partners indicated best aligned with their activities. And we also include a hyperlink to the funding announcement if available. This implementation plan is supposed to span 5 years from 2021 to 2025, but it may be difficult for agencies to predict what funding may be available during the later years of that time period. So future activities that are not included in this implementation plan will be incorporated in annual progress reports. Next slide. We requested federal partners categorize their activities along the viral hepatitis continuum of care. This chart in draft form quickly provides a snapshot of where the federal activities are focused along the continuum. This chart does not encompass all activities within the plan, as some activities do not fall within one of these categories. For example, the activity may support viral hepatitis work overall, such as through communication and coordination or raising awareness. So it did not get included in this chart. Next slide. So that covers the main components of the implementation plan. Next, we are going to hear from some of our federal partners on select activities that they would like to highlight from the implementation plan. Next slide. And first, I'd like to invite Dr. Wester to share CDC's activities.
Great, thank you very much. I will very briefly highlight some of the ways in which CDC's Division of Viral Hepatitis and more broadly support the implementation of the National Viral Hepatitis Plan. Next. In this slide, we highlight several of the areas that our integrated viral hepatitis surveillance and prevention support for health departments directly aligns with the implementation of the plan. You will see that the support crosses a number of different goals, including preventing new infections, improving the health of people living with viral hepatitis, reducing viral hepatitis related disparities, improving viral hepatitis surveillance and data usage, and also coordinating across all pillars. So for the first on the left, you'll see the surveillance outbreak detection and response awarded to 59 jurisdictions. This funding opportunity began in May of this year and expands for 5 years. It also has built-in elasticity, although the existing funding amounts are listed on this slide. And so although this crosses a number of goals, it specifically speaks to implementing the improved public health surveillance through data collection, case reporting, and investigation at the state, national, tribal, local, and territorial health department levels. In the middle, elimination planning, promoting access to prevention, testing, and treatment, again, crosses a number of goals. And the third, special projects to improve access to services for persons who inject drugs, also known as our PWID service bundle, which again crosses pillars, but specifically speaks to reducing new infections and specifically increasing viral hepatitis prevention and treatment services for people who inject drugs. Next. And on this slide, other CDC highlights include another funding opportunity that just started this year as well, National Viral Hepatitis Education Awareness and Capacity Building for Communities and Providers, which funds 2 organizations to develop community coalitions to increase viral hepatitis awareness, as well as increase the uptake of viral hepatitis testing and linkage to care, as well as a provider component to increase awareness and training in viral hepatitis screening, vaccination, and treatment recommendations. Also have a portfolio of national harm reduction technical assistance and also syringe service program monitoring and evaluation, which includes supporting establishment of syringe service programs, expanding services, including integrating clinical services and monitoring and evaluation, which also includes an annual survey and biobehavioral surveillance. And then finally, recommendations, research and policy monitoring supporting implementation of viral hepatitis prevention, testing, and treatment, which certainly includes, but is not limited to, the development and publication of national testing and vaccination recommendations, moving from risk-based to universal recommendations, which will also help support implementation. Thank you. Next. I'll now turn it over to my colleague, Dr. Hoofnagel from the National Institutes of Health.
Yes, thank you very much. It's a pleasure to talk to this group and represent the National Institutes of Health. Back to the next slide. Well, it's the National Institutes of Health. There are over 20 different institutes and centers that participate in this. Not all of them, but a large number of them contribute to viral hepatitis research. So here's an example of an initiative that was started by the National Cancer Institute. That's been, several others have joined, It's a webinar series on moving from hepatitis discovery to elimination. And this is a free webinar. It's monthly lectures on different topics related to elimination of viral hepatitis. And this link here will take you to there. You can register, it's free. And I can tell you about previous and future webinars. We've had them on prevention and on Delta hepatitis. We have one coming up on research towards developing a hepatitis C vaccine, a very important topic. Next slide. From my own institute, which is the National Institutes of Diabetes and Digestive and Kidney Diseases, or NIDDK, we recently started this initiative, which is a liver cirrhosis network. It's dedicated to all forms of liver cirrhosis, not just viral hepatitis, but allows us to do a prospective study on patients who have cirrhosis as a result of these diseases. Comparing and contrasting, we'll also test some new treatments for the cirrhosis itself. We have 10 centers spread across the United States and a data coordinating center at Northwestern. Very ambitious project that just started. Next slide. Perhaps the major contributor to viral hepatitis research is the National Institutes of Allergy and Infectious Diseases, NIAID, Dr. Fauci's institute. They have a primary responsibility for hepatitis C and B cure research, hepatitis C vaccination research, and in diagnostics. They, of course, are the major contributor to the AIDS clinical trial group, which deals with this community, and a lot of it deals with viral hepatitis co-infection. Our own institute is also involved with viral hepatitis, largely the disease as opposed to the virus or the immunology. We have a hepatitis B research network that has conducted 3 different trials of therapy of different forms of hepatitis B, chronic hepatitis B. Then very important is the National Institute on Drug Abuse, which follows a series of cohorts of people with injection drug use who have viral hepatitis. They're combined now into this group called C3PNO. It's basically three C's. They also have a very attractive and we think it's going to be a very interesting cohort of the Kentucky Viral Hepatitis Treatment group, which is looking at outreach and ways to reach these hard to reach communities and somehow decrease the burden of viral hepatitis in them. This is also co-funded by the National Cancer Institute. So those are just a few things that are being done in viral hepatitis by the NIH. Next slide. And thank you.
Hello, everyone. My name is Kristen Roja, and I am a public health advisor for HIV with the Substance Abuse and Mental Health Services Administration, or SAMHSA. Next slide, please. I just have one slide. So SAMHSA's mission is to reduce the impact of substance abuse and mental illness on America's communities. And we have a variety of activities that we fund to help address the syndemics of substance abuse, mental illness, HIV, and viral hepatitis. And I'm going to highlight 4 of them in this presentation. The first is the Minority AIDS Initiative High Risk Populations Grant Program, which focuses on increasing access to substance use and HIV prevention services for the highest risk and hardest to serve racial and ethnic minority populations. Grant recipients are required to test all clients who are considered to be at risk for viral hepatitis B and C, either on site or through referral. The second I'd like to highlight is the Minority AIDS Initiative Service Integration Grant Program, which focuses on integrated evidence-based, culturally competent mental and substance use disorder treatment with HIV primary care and prevention services to individuals with serious mental illness or co-occurring disorders with or at risk for HIV or hepatitis. The third I'd like to highlight is our Prevention Navigator grants, which provides services to those at highest risk for HIV and substance use disorders using a navigation approach to expedite services to these populations. The program's required activities include providing opportunities for screening and testing for HIV and viral hepatitis for individuals in this community. And then the last grant program I'd like to highlight is the Targeted Capacity Expansion HIV program, which focuses on high-risk populations, including racial and ethnic minority populations and LGBTQ individuals who have a substance use disorder or co-occurring disorder, who are HIV positive or are at risk for HIV or AIDS. And the required activities of this grant program include testing, vaccination, and referral and linkage to treatment and care management for individuals with or for viral hepatitis. So those are the 4 grant activities that I would like to highlight for today. And I'm going to go to the next slide. And so now I'd like to introduce Dr. Ronald Wilcox from HRSA.
Yeah, thank you. Good afternoon and good morning to everyone. As mentioned, I'm Ronald Wilcox. I'm a medical officer within the HIV/AIDS Bureau, a component of HRSA. Next slide, please. So, of course, we have lots of things that we're going to be doing with the National Strategic Plan. I just chose a few of the things that are being done across the agency to highlight for you. The first of those is that the ORHO is developing a regional harm reduction guide and some regional work groups, and that HRSA is committed to work with SAMHSA, CDC, and ORHO in developing as well as implementing the reduction guide, as well as the participating with the regional work groups. The second thing is HRSA has a Healthy Start program that works with pregnant patients or pregnant clients. And what we're trying to do with that in terms of hepatitis is to make sure that all pregnant patients or pregnant clients get screened for chronic hepatitis B as well as hepatitis C during their pregnancy, looking for early diagnosis and treatment when appropriate to decrease the chance of transmission to the infants. The third component for this is within the Ryan White HIV/AIDS program. The training arm of the Ryan White HIV/AIDS program is the AIDS Education and Training Center program. And the AETCs do training for medical professionals as well as healthcare team members across the United States and within each of its territories on HIV-related things. So we also teach a lot about hepatitis, viral hepatitis, both B and C, because of the increased incidence of those 2 diseases in people with HIV. And so one of the ways that we do it is through communities of practice. There's a program called Project ECHO that was developed by University of New Mexico. And through that, as well as other means, we gather people who do not have a lot of experience with either HIV care or hepatitis care. And they're allowed to present to each other different cases, and then they can have a discussion with experts about how to take care of that patient without the patient having to drive hundreds of miles to be seen by an expert. So this is one of the communities of practice ways that we do it. It's bringing expert advice with very minimal effort on the patient's part, other than going to their own provider that's involved. And we really are trying to aim this at racial and ethnic minority communities as much as possible. Next. In terms of some of the syndemic approaches, once again, the Ryan White HIV/AIDS program is one of their main tasks is to increase workforce, both numbers that are interested in doing HIV as well as viral hepatitis care, as well as their capacity in general. And so we're going to task the AETCs to make sure that whenever they're teaching about these issues, that they continue or increase their emphasis on the fact that these are syndemic factors and that they need to be working together to address all these things whenever you do that, not just the HIV or not just the viral hepatitis. There was a study that was done, funded by HRSA, that looked at some of the rural or urban differences within regarding HIV or Hep C and some of the outbreaks. And so we're going to be taking that data and distributing it more and seeing how we can implement it more widespread across the United States. There's also another study, I don't have it on the slide, but there's a special project of national significance that's going on that is looking at ways to increase the ability of doing hepatitis C surveillance by departments of health, with increasing their ability to do surveillance within Ryan White HIV/AIDS program funded HIV clinics. And that's an ongoing project that just started this past year. And then finally, we've started a syndemic steering committee that is working to make sure that we're not just addressing the viral hepatitis national strategic plan, but also taking into account different implementation plans for the STI national strategic plan, as well as the national HIV/AIDS strategy. Thank you. And next up is Rick Haverkate with the Indian Health Service.
Great, thank you very much. So I'll talk a little bit about some of the work that we're doing in IHS. I'm Rick Haverkate. I serve as the National Consultant Program Lead for HIV, Hepatitis C, and sort of the point of contact now for all things dealing with Two-Spirit LGBTQ+ issues. Next slide, please. A longstanding challenge in the Indian Health Service is that our facilities are predominantly primary health care, and they often exist far from specialist care. And this context makes telehealth a necessity. However, telemedicine or the usual one-to-one consults are really hard to scale. So the ECHO model provides case presentations with no personally identifiable information and engages several health clinics at once. So thanks, Dr. Wilcox, for giving some background on Project ECHO. During our ECHO sessions, many of the clinicians just sort of observe rather than present cases, but by doing that, they learn how to treat hepatitis C and can provide more HCV care and management on their own after participating in these ECHOs. And this model has gone from one single monthly clinic back in 2012 to now 6 per month to meet the incredible demand. And we've been incredibly delighted with how many patients and clinics we've been able to reach. Pharmacy data shows a high correlation between ECHO participation and direct acting antiviral prescriptions. So the more people are involved in ECHO, the more we see prescriptions for DAAs. And this correlation means that more patients are getting Hep C treatment in their community by medical teams that they know and trust. And in addition, these home-based medical teams provide holistic care. That holistic care is not often offered by referrals. Plus, traveling to these outside referrals can be really challenging for some of our patients who live in remote areas, especially those with poor transportation access. Next slide, please. IHS has chronically high vacancy rates, but those proportions are notably lower in the pharmacy layer of our clinicians. And our clinical pharmacists have proven ready and able to step up to HCV and other sides of the syndemics. And we really want to take advantage of this strength by supporting them. We have expanded the training and support we provide to all clinicians and have taken steps to directly address the exceptional leadership and skills that pharmacists bring to multiple services. They do an incredible job on numerous fronts, like local policy on screening and linkage to care, initiating treatment, consultation with specialists via ECHO, managing treatment adherence, and other critical aspects of case management. And in some settings, collaborative practice agreements with physicians and pharmacists greatly extend the range of guided services that those pharmacists provide. And in closing, in our IHS, tribal and urban clinics, we have seen an excellent access to care and high quality treatment outcomes from our clinics that support pharmacist leadership in HIV care. And now I'll turn it back over to Dr. Okeke to give us some more details on our next steps.
Thank you, Rick. Well, a special thank you to us federal partners once again for making out time from your busy schedule to joining us today's webinar and highlighting some of your activities in the federal implementation plan. By no means, this is not exhaustive. I will encourage folks to go to our website and read the federal implementation plan draft. We are continually working to break down silos in the ways that we do our work here at the federal agencies, while actively promoting collaboration amongst the federal agencies. This, of course, was demonstrated in the presentation you just heard. So next slide. So for the next steps, once the public comments period closes, which is by close of business tomorrow, Friday, November 19th, we will review all the comments and feedbacks and share them amongst the federal agencies for consideration. We hope to publish the final federal implementation plan before the new year, once it goes through the normal agency clearance process. This, of course, will be timely as we expect the new Syndemic Steering Committee and the reconstituted Viral Hepatitis Implementation Working Group to convene early next year, 2022. Of course, the Syndemic Steering Committee will equally address HIV and its endemics, including STI, mental and behavioral health. The intent for the Viral Hepatitis Implementation Working Group is to serve as a subcommittee to the Syndemic Steering Committee. Both bodies will work in identifying areas of collaboration and importantly facilitate cross-disciplinary funding services and communications. Also, the VAIG will also help to update, review annual reports. Finally, as I stated earlier, the Viral Hepatitis National Strategic Plan requires the whole of society approach. Clearly, there is an extraordinary amount of work to be done, yet to be done, to achieve our elimination goal. But we are all in this together, right? As partners, both federal and non-federal partners, stakeholders, understanding that the more that we communicate, work together, the better we will be able to move the needle and reach our goal. Next slide. Okay, now I will quickly hand things over to Jessica for the public comment section. Jessica.
Thanks, Janedo. All right, before we begin the verbal comment process, I would like to remind everyone that we are still collecting written public comment. They are due by tomorrow by 5 p.m. Eastern Time. If we are unable to get to your verbal comment today, please provide your comments to us by submitting them to the email address here, hepatitisplanncomments@HHS.gov. You may also submit written comments through the chat on this webinar, and you can submit them at any time now. All of the comments will be reviewed and disseminated to our federal partners. The public comments submitted now may not be able to be included in this implementation plan, but they will certainly be disseminated to partners to possibly inform future activities. Next slide. All right, so now I would like to open the verbal comment period. The webinar is being video recorded to provide complete and accurate record of the comments. There is no other opportunity to provide verbal comment outside of this webinar. So I would like to now invite anyone wishing to provide verbal comment to go ahead and raise your hand. There's a button on the bottom of your screen to raise your hand, and we will call on you in the order that your hand was raised. Please keep your comment to under 3 minutes to allow others time to participate. We will unmute your microphone to begin and mute it when you are finished. Please identify yourself by name and organization before you begin. And just to note, we will not be responding to any verbal comment during the webinar, but if you have any clarifying questions, you may enter them in the chat. I'm seeing comments that say, okay, you have the raise hand button now. Good. So if you have any clarifying questions, you can enter them in the chat and we will try to respond by chat back to you. All right. So please go ahead and raise your hand if you would like to make a comment. So the first comment I see or hand raised is from Rita Kuwahara. Go ahead.
Hi, can you hear me?
Yes, go ahead.
All right. Hi, my name is Dr. Rita Kuwahara. I'm a primary care physician and health policy fellow at Georgetown University. Thank you for the opportunity to provide public comments today. It is wonderful that the Viral Hepatitis Strategic Plan embodies a framework of elimination. Today, I would like to focus my comments on the steps we must take to achieve hepatitis B elimination in the US, which is an issue of health equity. Up to 2.4 million people in the US have chronic hepatitis B, and we've seen alarming rises in acute hepatitis B of up to 100 to 400% in states most affected by the opioid epidemic, driven largely by our extremely low adult hepatitis B vaccination rate of just 25% in the US. Further, the CDC reported that 36% of new hepatitis B infections in the US were attributed to the opioid epidemic. During the recent CDC Advisory Committee on Immunization Practices November 2021 meeting, the committee took a monumental step forward in recommending universal adult hepatitis B vaccination for all adults aged 19 through 59 years old and risk-based vaccination for adults over 60. This new recommendation is critical to achieving our goal of hepatitis B elimination, but adequate federal support and funding to implement this new recommendation is essential to achieving our goal. Federal efforts must be made to develop educational materials to raise physician awareness of the new recommendations so that they routinely order hepatitis B vaccines for their patients. This is a critical step since a small survey we conducted of primary care physicians showed that 0% surveyed physicians knew that the adult hepatitis B vaccination rate was only 25%, and most incorrectly thought the vaccination rate was over 75%. We must also provide resources to enable practices to stock hepatitis B vaccines in clinic. For patients without insurance, it will be important for states to receive adequate Section 317 funding to stock and administer hepatitis B vaccines for adults requiring vaccination. Efforts must also be made to ensure that patients at greatest risk of acquiring hepatitis B who may not have regular access to healthcare services are able to receive the hepatitis B vaccine in non-clinic settings such as syringe service programs and other community outreach programs, and that these non-clinic settings receive reimbursement for delivering these vaccines. In addition, we must strengthen pharmacy clinic communication so that primary care clinics are notified when their patients receive a vaccine in the pharmacy. Further strategies must be implemented to ensure patients return to receive follow-up doses of their hepatitis vaccines to achieve full immunity. Federal strategies must also be developed to ensure that patients are tested for hepatitis B so that those with chronic infection are diagnosed and linked to care, since 2/3 of patients are unaware of their diagnosis. Lastly, we must expand the immunization infrastructure we developed to deliver COVID-19 vaccines to administer other vaccines such as hepatitis B, and we must create a federal immunization information system that allows state immunization information systems to communicate across state lines so that patients who receive vaccine doses in different states maintain a single vaccine administration record. Hepatitis B vaccination is our primary tool to achieve elimination, and please let me know if I can be of service as you develop strategies to implement the new ACIP recommendations and National Strategic Plan. Thank you.
Thank you, Dr. Kuwahara. Next hand I see is Daniel Raymond. Please go ahead.
Thank you. This is Daniel Raymond with National Viral Hepatitis Roundtable. I appreciate the opportunity to comment. I have an overarching comment that I'd like to go a bit narrow in terms of getting to the point I'm trying to make. Last year, a team at CDC published research in Journal of Infectious Diseases analyzing clinical encounters for people with diagnostic or procedural codes indicative of injection drug use, and found that less than 10% of them received screening for HIV or hepatitis C within a year of the clinical encounter. In looking at the implementation plan, this feels like a clear opportunity to increase screening rates, but it's unclear to me whether there are any particular activities that could move the dial on those numbers, and whether there are any particular targets for reaching saturation of screening and diagnosis amongst this population in clinical encounters. And I use this as an illustration to suggest that as we look through the implementation plan, there's a sense that there's a lot of gaps in the overall federal response and a lot of opportunities here, but it's not clear how the activities listed, how far the federal government expects them to move us to closing those gaps, and what further action is needed. And so I say this in the interest of sparking further dialogue with the broader hepatitis community as HHS implements this plan, but also to say that there really needs to be some new kind of push, maybe comparable to the Minority AIDS Initiative, say a Secretary's Viral Hepatitis Elimination Catalyst Fund that could solve these issues and really invest targeted that are tied to specific measurable benchmarks that will have the broadest possible impact. We will be submitting further written comments tomorrow. And again, thank you for this opportunity.
Thank you for your comments, Daniel. Next hand is from Carl Schmidt. Go ahead.
Carl, go ahead. You're being unmuted. Carl, you may unmute yourself. I don't. Oh, there you go.
Okay, now I didn't see that little direction. Could you hear me now?
Yes, perfect.
Okay, good afternoon. I'm Carl Schmidt with the HIV and Hepatitis Policy Institute. Thank you all for your efforts in putting together this implementation plan. We know that we cannot achieve the goals of ending hepatitis without increased funding for the key elements of the strategy, including testing, treating, and vaccination. Increasing resources for the hepatitis elimination must be our first priority. While this plan was drafted with current resources in mind, there are areas where I would like to suggest some strengthening. In the area of outreach and awareness, I would include participation of the Surgeon General with his bully pulpit, greater use of the Assistant Secretary of Health and the Secretary as well. I found the section on improving outcomes for people with hepatitis the weakest. With a miracle cure for hepatitis C now available, which is key to elimination, that section did not lay out a plan to increase testing and improve treatment access. Instead, it just calls for more studies. For example, for barriers of reimbursement of preventive services such as testing, it calls for more research, even though we've been dealing with these issues for years. Same for barriers for insurance coverage of treatment and prior authorizations, just more research and new payment models. There's no mention of the Medicaid barriers. Our government can just act and enforce the laws now. The cost of the drugs have come way down, and I don't understand why we're allowing payers to discriminate against people with hepatitis. You should call for enforcement of ACA non-discrimination and Medicaid laws. There's little focus on using the Ryan White program for the co-infected, just a discussion of training, and no mention of the community health center programs to increase testing and treatment. They both are currently doing it, but can always improve. As a person living with chronic hepatitis B, I was pleased to see Dr. Hoofnagel and the continued focus on finding a cure for hepatitis B. In the surveillance and data section, I also like the use of IQVIA's hepatitis data to track treatments over time and by payer, and incorporating hepatitis in NHANES. And certainly supportive of the syndemic approach while you also work on HIV and opioid epidemic. It's great to see the establishment of a syndemic steering committee. However, I think the plan should detail how you will implement this approach, such as including hepatitis and HIV funding announcements and ensuring greater accountability. And speaking of accountability, we also recommend that the implementation plan include an establishment of an Ending Hepatitis Federal Advisory Council. The plan acknowledges that it can't be implemented by the government alone. Having an outside group of experts and community to advise you and work with you can only help us ensure that the strategic plan is implemented in order to end hepatitis. Thank you.
Thank you, Carl, for your comments. Next hand is from Lauren Sant. Go ahead, please.
Thank you very much. Thank you very much for this opportunity. My name is Lauren Sant. I'm with the Caring Ambassadors Program in Portland, Oregon. I just have a couple of comments. I feel like we need a roadmap to who is doing all this work. It's one thing to say CDC and to put a grant number there, but who are the partners that are actually doing the work so that we know who to reach out to and who to communicate with as a community so that we can continue to do the good work that's being done. And so if NASTAD has the grant, then it should say CDC and NASTAD or CDC and Hepatitis B Foundation, whoever it is. We just need a roadmap to know who to work with. And I don't see any of these partners listed in the working group. And you say it's a federal plan, but you can't do it without your partners. And so we just need to know who they are, and so we can be more efficient on our end. There's definitely not enough time for sufficient detailed feedback from all of us. I wish we'd been given at least another week to look this over. It's a lot to take in, and there's a lot of missing pieces as to who's part of doing this partnership. So I also think that there's a very big assumption that primary care providers are going to pick up treatment, and that just doesn't happen. Echoes are fantastic and they do a great job, but we're not seeing a great increase in primary care picking this up. And so I think there needs to be a huge focus on how to get doctors to treat the population that's left living with hepatitis C. Thank you. I look forward to working with all of you on this and appreciate all the work that's gone into this.
Thanks so much, Lauren. Next hand is from Franklin Hood. Go ahead, please.
Thank you. My name is Frank Hood, and I am the manager of hepatitis advocacy at the AIDS Institute. And I appreciate all the work that went into crafting this implementation plan and the opportunity for us to speak on it. I'm going to reiterate a couple of things that have been said. First, to say that while I recognize that OIDP is hoping that this implementation plan can go through review and be live for the beginning of the year, I strongly urge that you give us another opportunity to spend more time with this document, and to have another written comment opportunity to come back and provide feedback, because like Lauren said, being able to go from Monday to now to really digest this, think critically about how each of us can be supportive of the plan, as well as highlight areas that have been missed. There's just not been enough time. And I'm concerned that by not having enough time, that some important information and voices are going to be left out of this conversation, and thus kind of left as it continues out of the station, and thus weakens the implementation plan. Additionally, I will also reiterate that non-federal stakeholders need to be part of the working group or some other entity connected to this as it moves forward, and that those meetings need to be public. Page 1 of the implementation plan does say that it takes more than the federal government, and many of the funding mechanisms listed in this plan are actually subgranted out to CBOs and others on the ground, but they have not been a part of the implementation planning process, nor have they been included in the plan to be looked at or considered during the execution of this plan moving forward. Additionally, we want to say that to the point of additional information, we have agencies listed like HHS and CDC, but these are big agencies and departments, and who is in charge of each action plan is more than just that. It's maybe it's DVH or a national center here, or risk reduction there. Having these more specific programs listed under the agencies would really help non-federal stakeholders know who to go to and who to discuss specific action items with. Additionally, to the point that was just made around grantees, having those grantees that are expected to be doing some of these action items more specifically listed than just who they're what federal agency oversees that money would be helpful for us to go and directly work with those others on the ground that are doing some of the action items on this. And then lastly, I want to really focus to say that Clearly, there are many moving functions within the federal government that move toward implementing this plan, but I'm a little concerned that the plan doesn't talk about strong or robust federal leadership to oversee it. And so do urge that the final plan include more on how all these moving parts will have a stronger federal leader behind it. Thank you.
Thanks for your comments, Frank. Next hand is from Kate Morales. Go ahead.
Kate, you may
Thank you. I
unmute.
just,
Yep, you've got it.
Thanks. Thanks so much for the opportunity to provide comment today. My name is Kate Moraz. I'm the Deputy Director of Public Health with Hepatitis B Foundation. I just have a few comments and we will be providing additional written comments as well. Overall, I just wanted to echo a few comments made prior to this around action steps that could be further expanded and elaborated. We appreciate the transparency of providing the funding mechanisms for the action steps listed in the plan. And these are very helpful and valuable as well to the work that we do. And we understand the limitations of the plan due to funding, but I would like just to echo that there is an opportunity to provide additional action steps with the input from community stakeholders that will move us further towards the needle of eliminating hepatitis B and C in the US. Additionally, providing additional action steps that are effective will help us with, will provide us with the advocacy tools that we need as well to support increased funding mechanisms to implement the plan. And I just wanted to note that related to the harm reduction strategies in the plan, CDC surveillance data show that 36% of new Hep B infections occur among people who inject drugs. There is clearly a need for training and technical assistance related to hepatitis B preventive services. And I just wanted to make sure that folks are cognizant that hepatitis B is not left behind in the strategies, objectives, and action steps that are related to harm reduction. For example, in the development of the Regional Harm Reduction Guide and activities that are planned to be implemented by SAMHSA as well as HRSA. And then finally, with the anticipated universal hepatitis B screening guidelines, we want to make sure that the plan is reflected of these guidelines that are planned to be released in early 2022, and that it's important that implementation of the universal hepatitis B screening guidelines are reflected in the plan. Thank you very much, and we will provide additional written comments as well.
Thanks so much, Kate. Next hand is from Scott Bertani. Go ahead, please.
Hey, thank you for the opportunity to weigh in on the draft implementation plan, and we're grateful for the approach that you're all taking to this work. So I am Scott Bertani, Director of Advocacy for Health HIV, and quick background, Health HIV is a national nonprofit that works with communities and healthcare providers that advance effective prevention care and support for people living with or at risk for HIV and viral hepatitis through education and training. And we do technical assistance and capacity building, advocacy, and health services research and evaluation. And, evidence shows that about 1/3 of providers are unable to treat a patient with viral hepatitis C due to payer or insurance limitations and restrictions. And many HCV service providers are really failing to implement the CDC screening recommendations for HCV, with about less than half of providers screening some of the most vulnerable populations, including those with substance use, patients living with HIV, and baby boomers. And patients really experience lengthy prior authorization and pre-approvals, which often turn them away from from accessing some of that necessary care for their condition. And even when patients are given access to testing, many drop out of care following diagnosis. So especially patients who are also being treated for substance use. And hepatitis C elimination is only going to be possible if we have a comprehensive federal and state plans that address the intersections of the opioid use disorder, hepatitis C, HIV, and STIs across the US, and you're making strides in that. But it also starts with making the proper investments to address the community engagement and access barriers, especially with respect to outreach, screening and testing rates, and follow-up from primary diagnosis. And the concern is that in the plan, as you mentioned, not all indicators or steps are aligned with funding mechanisms in stream, and there isn't a plan for greater reimbursement mechanisms in the such. And that is especially true for people on state Medicaid programs where treatment access is often restricted through cost containment strategies. And that also includes focusing on enhancing the plan's capacity to work and to communicate and coordinate across the partners and the grantors doing the work. So I would echo from my colleagues that there ought to be additional time to review this implementation plan a little bit more thoroughly across the partners and the grantors and the intersecting communities. And getting it right with the first national plan is so important in advocating for elimination of all the viral hepatitis. Thank you.
Thanks so much for your comment, Scott. All right, I am not seeing any additional hands raised, so that will conclude the verbal comment period. If you didn't get a chance to provide verbal comments, you are still able to provide written comment to hepatitis plan comments at HHS.gov. Thank you all so much for contributing your comments today. We will take them all into consideration and disseminate to our partners. Thank you so much for attending today and have a great rest of your day.